while we're waiting to start, just one more push for the fundraiser. IPACNS@gmail.com for e-transfers.
Thanks, Dwayne. It looks like almost everybody is, they're trickling in. But for the sake of time, it is Friday late afternoon. We'll get started, or I guess mid-afternoon, not late yet. So your fifth session today is Guardians of Tomorrow, Redefining the IPAC Practitioner. And your speaker is Erica Susky. Before I get into her real profile, I'm going to mention that Eric and I worked together for a couple of years back in 2010 to 2012. And now we work a little bit together in the IPAC Canada online course. So we have a long history. Erica Susky has a Master's of Science and her CIC in Infection Control and is a teacher and a consultant. Her experience includes acute care, mental health, long-term care, rehab, outpatient settings, and most recently, shelters and congregate settings. Erica has interests in education, research, antibiotic resistance, and clinical microbiology. Her training included studying antibiotic resistance at the National Microbiology Lab in Winnipeg, where she acquired a master's degree in medical microbiology. She's published in international scientific journals and has presented at conferences pertaining to infection control as well as antibiotic resistance. She's currently on the IPAC Greater Toronto Area Chapter Education Committee and is the associate editor for the Canadian Journal of Infection Control. She's also working with the cardiology program at St. Michael's Hospital at Unity Health Toronto. Erica, over to you.
Thank you. As I was trying to adjust the screen, I just want to make sure, can you hear me okay?
Yes.
Oh, okay, wonderful. Thank you for the introduction, Angela. And I think it's very interesting that I'm giving a talk entitled Guardians of Tomorrow about the role of an infection control practitioner. And the reason why I think it's an interesting occurrence is because Angela, I first met Angela when I was a baby of infection control, and she was teaching me how to start to be an infection control practitioner. So let's see that these arrows do work. Not that arrow, but maybe this one. There we go. So there is an interactive component to this talk. Go to menti.com or scan the QR code, or sorry, enter the numeric code on the left or scan the QR code on the right. And I can see some people are getting in, and you can click thumbs up when you're in. And also, thank you very much for having me here today, virtually. I'm very excited to be giving a talk to the members in our profession in a new province for me, Nova Scotia. Happy IPAC week. I think it's just ending now. Do you think, Angela, that we're just under half of people in?
Yeah, I think we're good to start going.
Oh, you want to start now?
Yep.
All right, great, thank you. Let's see if this arrow works now. Oh, it does. Wonderful. So I just like to start taking this way back when I first met Angela and I was a baby in IPAC, infection prevention and control. And I had a lot of enthusiasm for working in IPAC. I had yet to acquire the curse of knowledge. And when I used to describe to people what I do for a living, infection prevention and control, everybody saw and appreciated what I did. They could understand what I was doing for my job because I described it in simple terms. I didn't yet acquire this curse of knowledge. And now, to be honest, when I talk to people outside of my work about my job, their eyes will often cloud over and they get bored because I now let technical jargon slip in. However, just to get back to what we do in the simplest of terms is we keep people from getting sick. So I have this question up here. Have you ever been so sick that it has just wiped you out for a few days? And I do remember an instance like that. And I think everyone, most everyone will, because really everybody knows what it's like to be sick, and thus everybody can appreciate the job we're doing. And people spread information through stories. So I just like to give you a really good story I got from one of my colleagues last year, just to show why we do is so important. So last year there was this man, and he had a complex pulmonary history. He had a history of a double lung transplant. He suffered a fall, broke or injured his hip, and that's why he went to the hospital to have his hip fixed. While he was in the hospital, he was exposed and acquired COVID-19 pneumonia. Because he was immune suppressed, we had to keep testing him over and over and over again until he was negative for COVID-19. He cleared the virus. That took a long time, and he was on isolation. I mean, I'm saying isolation on purpose because it is isolating. There are published negative repercussions for somebody being on additional precautions for too long. And well, this occurred. He suffered subsequent aspiration pneumonias and a fall. Fall, is it from the isolation? We can not tell, though there's published data showing that people on additional precautions will spend less time with healthcare providers. Healthcare providers will come in the room less often. And he was on hemodialysis, and maybe because of the additional precautions, these things were contributing that he couldn't get a rehabilitation bed. It was harder to get safe accommodation for him, and this whole thing was very frustrating for him. And he then later developed C. difficile, and because of his depression and his ongoing pain, he decided he didn't want resuscitation. He ceased his treatment, and he eventually died from C. difficile colitis. And I know in our field, it's not just about stories. We want hard data. So, I mean, we heard from the previous talk from Andrea Patti that healthcare-acquired infections are one of the top 10 causes of death in healthcare worldwide. And I'll share with you some data I got. It's from the Provincial Infection Control Network of British Columbia, that 1 in 9 patients will get healthcare-acquired infections. So, like this man, he had a hip fracture, and about 1 in 9 people will leave the hospital with a problem they never even had when they came in the hospital. And in this case, this man, well, he didn't leave, or maybe he left in a body bag. He died, and a lot of these are preventable. And the COVID-19 pandemic, maybe it makes a lot of people want to forget about IPAC, forget about infection prevention, because it was a rough time for everyone. And I'll certainly admit it was a rough time for me. People saw the negative repercussions of IPAC decisions as we tried to get a hold of COVID-19 transmission. And certainly it gave me some new perspectives in infection prevention and control. Though I also think that now is a great time, and it's apt for IPAC week, that the pandemic is behind us, and we could take a time to pause, reset, and renew, because I mean, what we do is great. And I'll share with you some stories and data to show the effectiveness of our roles. This here was shared by one of the clinical team members. I used to work with this person at a past organization, describing what IPAC is to them. Keeping patients safe, listening to concerns, high quality work, dedication. Each and every one of you in the audience is incredible. And yes, I'm naturally pessimistic, and IPAC can be pessimism focused, as we're always trying to plan for the worst case scenario. But these are the kind of things I like to save and hang up in my office as a gratitude wall to give me some time to think about the positive. It's really important, not just to worry, but to think about the positive. So here, I've shown this slide a lot to Ontario audiences. I don't think anybody's seen this slide yet. Why I want to show you this slide, it's data that shows that IPAC programs work, that we prevent people from getting antibiotic-resistant bacteria. So this is with CPOs, carbapenemase producing organisms, that with the introduction of IPAC programs, there's a sustained decrease in new residents getting CPOs. A little background in this is from Israel. In 2007, their whole country had a CPO outbreak, and they had very little by way of IPAC programs. So they started putting a lot of investment in IPAC programs in the acute care hospitals. Then in 2008, they moved the IPAC programs to the long-term facilities. So on the x-axis, you could see there are 3 long-term settings: nursing homes, post-acute care hospitals, skilled nursing facilities. And the left y-axis is the change of CPO acquisition since shortly after they brought IPAC programs into these settings. And you see the different colored bars are from 2010 to 2015, and eventually a sustained decrease of new residents getting exposed and getting a risk of getting these highly antibiotic resistant infections. And something to add about this too is, in these settings, they're not even that restrictive. They don't put people necessarily on contact precautions, but all the other IPAC measures that we instill in a program will still contribute to improved outcomes. And this study is from the United States of America, USA, showing that if nursing homes invest in IPAC professionals in their staffing and their training, there will be a reduction in COVID-19 deaths in these homes. What they did was they took public health data from 857 nursing homes across the country. So they took public health data from the adjacent homes to get an estimate of how many COVID-19 nursing home deaths were in these homes. And you could see that on the left y-axis, predicted nursing home deaths per 1,000 residents. And they compared that to the deaths in the community. And you see that on the below x-axis, decile of county deaths per 10,000 population. What they did was they compared different professions and their level of IPAC training in these homes. And they found that a licensed practical nurse, or LPN, with no specified IPAC training, that's the blue line emphasized in the red rectangle, saw significantly higher COVID-19 deaths in those nursing homes. And you could see as you move to the right of the graph, that blue line widens with all the other lines, which is an LPN with IPAC training and advanced clinicians dedicated for the IPAC role. And this is a statistically significant difference. And in this study, it wasn't even necessarily a lot that was described as IPAC focused training. Of course, it could be a certification in infection control. It could be education from a professional society, or anything described as IPAC focus. So for example, if we're in our role dedicated, we're not trying to do 2, 3 other jobs at the same time, even with minimal IPAC training, we could do as well as an advanced clinician and save lives. Now, okay, so there's data to show that our role works, but what's in the secret sauce? How do we affect change in others? Because we certainly can't prevent healthcare acquired infections on our own. Now, I want to ask you guys, before we get into some mechanisms of influence, what do you guys use, or how do you affect change in others as an ICP? You can type in 1 or 2 words. And don't be shy. Facts education. Oh yeah, lead by example. Oh, I love this thing, thank you. Support, listening, relationships. Oh, okay, you guys already have some down that are some well-known mechanisms of influence. Education.
Erica, are you able to see the chat?
I cannot. I just want to make sure that I can see the screen properly. Are there questions or anything?
No, just some comments. I'll read it. I'll read them out. So
Okay.
goodwill.
Goodwill. And,
leading by example.
Yes, I agree.
And education. Hand hygiene auditing.
And it's interesting, lead by example. So when I was my baby ICP, infection control practitioner, I'm like, all right, I'm gonna wash my hands all the time. And then when I did that, I actually started getting sick less often.
Imagine. There's a really great comment here, Erica.
Yeah.
I work as a floor nurse, 0.6 and 0.2 IPAC, leading by example and through my relationships.
Sorry,
this is one. It's a nurse who works on the unit part-time and in IPAC part-time. And so she leads by example through her relationships with her peers.
Oh, so already established relationships as not IPAC, which
magic.
Is magic, but not for me. I had to work via other channels. This is wonderful. So happy that you're all sharing things. So you guys already guessed that some of the mechanisms of influence, and I'll go over a study that establishes 3 mechanisms of influence. Here we go. It is personal interactions, data reporting, and education. This is another USA study. They found hospitals from various regions of various sizes, various rates of healthcare acquired infections. The one thing they wanted is that the hospital to participate needed a medical surgical ICU and at least 500 device days per year. So they were able to find 19 ICPs and interview them to see where they exert their influence. And you could see personal interactions. It's at the very top. I didn't put that there by accident. This interview, and also speaking to multiple ICPs across the country, that these 3 are important, but if there is a number 1, it's certainly the personal interactions, the relationships that we develop that are most important. Here is where our IPAC Canada profession lies. think this is late 2024 or early 2025 data. On the left, we've got our years of experience, and on the right is educational background. So let's focus on the years of experience. In blue, you could see about a third of us have over 10 years of experience, and about 1 in 5 of us in yellow are just starting off on our career paths with under 2 years of experience, which is great because we have fresh ideas, fresh blood, and it's also good too because likely you've heard of a lot of experienced professionals leaving healthcare during the COVID-19 pandemic. It doesn't seem to have hit us as hard. We still have a lot of people who have experience well before the pandemic that remain in our profession. So our profession has a good capacity for mentorship, and mentorship is a two-way street. It's not just about more senior ICPs imparting wisdom on newer ICPs, but the newer ICPs can teach us oldsters a thing, because I'm in the over 10-year category right now. And it's a good time to mention that IPAC Canada has an excellent mentorship program. Now on the right, our educational background. In orange, you could see about 1 in 4 of us have backgrounds described as other emergency medical services, dental, microbiology, and others. And disclosure, my background's microbiology if you detect any biases. You could see historically IPAC was a profession of nurses, and nurses or nursing backgrounds are still the majority of the profession in blue. Though IPAC, it does require all that good clinical knowledge and bedside manners knowledge that nursing provides, though our field is also specialized and requires knowledge from other backgrounds: microbiology, statistics, epidemiology, infectious diseases, and others. So now I want to ask you guys, do we have oldsters like me, over 6 years of experience as an ICP, 2 to 5 years, 1 to 2 years? Ooh, brand spanking new. Look at that. Wonderful.
And Erica, in the chat, we have somebody who has put in 4 years.
4 years, all right.
Mhm.
I think I'd say, I can't really see, I don't even know if this is relative to proportions or not, but to me, I'm just seeing kind of a similar thing: fresh blood, but also people with experience, which I think makes for an excellent mixture. And then, what's your educational background? Now, I already know in Nova Scotia, you're all nurses, though I'd like to see if there are any other educational backgrounds hidden within. A microbiology. That's awesome. And then, just to type in, I mentioned some other fields, but if you feel there are any other educational backgrounds that could benefit an IPAC team. Now, one that I could think of that I touch on a little, I'm no expert, is knowledge implementation, knowledge translation. Medical technologist. Epidemiology. I feel for me, the epidemiology is pretty good because I'm not the greatest at generating in a meaningful way the data. Biological engineering. Oh, that's interesting. Construction. That too. When I started in IPAC, I was all like, oh, why is there a construction chapter? That's weird. But it's not. I like
Erica,
how,
in
yeah.
the chat, we have another epidemiologist and a pharmacist.
Ooh, wonderful. Oh, pharmacy. Antimicrobial stewardship is near and dear to me. I used to go to the antimicrobial stewardship rounds, and it's helped me so much to make me a much better ICP. All right.
Environmental services also entered the chat.
Wonderful. Yeah, this is great. So I mean, like, there's just a lot of knowledge that can be encompassed in infection prevention. So as I mentioned, we place a lot of value in our personal interactions, being part of the clinical team. In fact, we need their support. We can't prevent healthcare associated infections by ourselves. We're considered consultants and leaders. And in that way, we need to bring as many people to the table as possible, from the very top, but also to the front lines. And I would think especially the front lines. And in order to involve the front lines, we have to be accessible, visible, and available. So from this study, I'd just like to share a quote: "Get out of my office, stop crunching numbers, and be out there." Now, why am I showing this picture of Jerry Seinfeld? This was after he went on a first date with somebody. She eats her peas one at a time. Well, I've already mentioned my background is microbiology. I am a nerdy scientist, and no training on bedside precautions, and never once in my life has somebody used the adjective charismatic to describe me. But the way I see it is being an ICP is much better than being on a first date or being at a job interview. In thinking of the setting in the hospital, you get to see the team members, interact with them repeatedly, and over time you build charisma. So certainly I have had interactions that could have been better, though I get time to perfect my skills and improve. And it's interesting, the more I give this talk, the more I learn on where our field is going. When I gave this once, for example, in Ontario, we have ICPs working in clinics, we have ICPs working in shelters. And one of them in these settings, they mentioned that to them, it is a little bit more like a first date. They don't see these people as often, so they kind of do have to win them over the first time they see them. And I mean, to that, I'm like, that's great. I don't know how good I'd be at that, but you could see that an ICP needs to be very skillful and draw on a lot of skills: emotional intelligence, leadership skills. Now, our second mechanism of influence is the hard data, the science. And of course, we want published studies informing our decisions. However, in this study, they found that with the front lines, what really resonated with them was the data reflecting what's going on in their area. And that's what matters to them. And what we can give them is that data, but appropriately graphed out in ways that are easy to understand, to tell a good story. For example, do we want crude numbers, rates, proportions, quarterly data, annual data? And from this way, we could certainly draw from our colleagues in epidemiology. However, the more I get into infection prevention and the further I get away from working in the lab, I realize that the data, don't want to say it's worthless, but like the value of the data is augmented so much more by the relationships you have with the people. So if the data is just there by itself, what good is it going to do? So in this study, we've got good data plus good relationships equal credibility. And certainly we've seen people who dismiss the data, or worse yet, disbelieve the data, for example, with vaccine hesitancy. So it's really important for us to develop those relationships. So then with the good data come the credibility. Now, the third mechanism of our influence, education, and that is bringing to life invisible threats. The picture on the right, you can see the enormous purple thing is E. coli, which is microscopic. But right next to that, you see extremely infinitesimally small viruses. So we have to make people's behavior get changed due to these invisible things. And with this, the challenge is also, you can't exactly say at what point this person there that didn't wash their hands gave an antibiotic resistant bacteria to that patient. And in that way, just like with the data, it's important that we cater our education and our messages to the time, the moment, the audience, that it's relevant to the clinicians, the so what, as it were, based on adult education principles. And for people that may not quite believe things so easily, that need a little bit of selling, the ICPs in this study noted that they preferred using coaxing for these instances. And they also mentioned that the unit staff appreciated the feedback on a regular basis, but they didn't just want the feedback based on things that you were doing wrong. They also appreciated the feedback on successes to help with motivation. And I myself, I really enjoy giving that feedback too, because we feel better about things. So to quote an ICP, in this study, you just have to take it little bits at a time. You can't just say we're doing this and it's either a success or not. It's just incrementally. And the way I see it is this change, it takes time, just like carving a statue out of stone. I've never seen a stone statue being carved, but I imagine it would take a lot of work over a long time. And in that way, doing our job is about choosing battles. For example, on the below x-axis, imagine these are 7 things that's going wrong on a unit to allow for the spread of, say, MRSA. We don't just want to tell them, you're doing these 7 things wrong, change them right now. That'll likely overwhelm them. The way I like to see it is maybe 1 or 2 things to focus on. And this here is a Pareto diagram. There we go. Based on the Pareto principle. That means that 20% of items will affect 80% of change. So you can see the left y-axis is the frequency of change. And then the right y-axis is the cumulative change when you add the different items together. So for example, put your energy on item A in the red rectangle to the left. That'll make a much bigger difference. Don't waste your time putting all this effort in item G on the right in the red rectangle. And for us, ICPs, we know about the mechanisms of transmission. So certainly we can help in determining what will really affect a change, though also the solution most often lies with the front line. So it's once again us bringing the frontline people to the table because they see a lot that's going on and they will have the greatest ideas to change things. And also if we listen to them and put our energies into changing what they think matters, there will be a much more success by way of the maintenance of said changes. And I'd like to give an example. I love going to the safety huddles because like I really want to be present and be part of the team. And I used to work on a stroke unit. They had ICU step-down beds, and these beds, they had 4 bedded rooms. You know, we were not big fans of 4 bedded rooms. And once every month, or maybe once every 2 months, a patient would get MRSA associated with one of these ICU step-down rooms. And I saw that they had these carts with the clean supplies right in the rooms. And of course, we would never want clean supplies stored in a patient room. So during the huddles, I mentioned this to the staff, and their concern was these are ICU patients and higher level of acuity. They wanted the supplies ready at hand in case they needed them. So they wanted the supplies ready at hand, and me opposing things saying, you can't keep these things in the room. Well, I mean, does it seem intractable? Well, during a huddle, one of the nurses on the unit mentioned, well, we've got like these small plastic containers, or they can be bought for not a lot of money. Can we just fill them up for that patient we're looking after? And then at the end of the shift, whatever's left over, discard them and then wipe out the container to give to the next person. And like, they're asking me permission to do this, but I'm like, oh, why are you asking me permission? Like, that's a great idea. So I'm like, yes, that's great. And after that, they just went with it. And it just never was an issue again. No more MRSA associated with these rooms. And just a midway break, just to summarize, the ICP, our work is really important. We keep people from getting sick. We really want to be part of the interprofessional team. We value our personal relationships. And it's not just personal relationships with the interprofessional team, but also our relationships within IPAC Canada, which is why I'm really happy you guys are having this event. Like, I've gotten such enriching relationships across the country. It's wonderful. And you could see the last point, our mechanisms of influence. Number 1, personal interactions. We help out with our data, our science, and our education as well. So now this study, first studies were Israel and United States of America, but this one is from IPAC in Canada. Now, what they wanted to determine is what would hinder nurses complying wearing PPE or personal protective equipment for people on additional precautions. So here, well, first of all, before I get on, it's important to know what the barriers are. If we know what the barriers are to compliance, then we can help in reducing those barriers. Now, the second point, you could see the 4 barriers that they identified in hindering compliance: education, patients, support decision-making, good practice, and regular audits. Seems weird that those would hinder compliance, but the way I see it, it's two sides of the same coin, which I find extremely interesting. This is from a 148-bed acute care hospital in British Columbia. They had 8 nurses from different areas in the hospital, and they drilled down to these 4 core issues using the Delphi technique. So they had expert interviewers with expert guided questions. They were iterative questions until the group came down to this expert guided consensus. What this shows is that it's really important to have this constant communication. So we see the ICP at the top, the unit staff to the left, and the patient to the right. Let's take, for example, decision-making and how it could either help or hinder compliance to PPE. So for example, on the left, we see the ICP interacting with the unit staff. We do this quite a bit. And the unit staff in this study, they already made their assessments, and what they thought was somebody on contact precautions for MRSA was less of a risk than, say, somebody on droplet precautions. So they were less likely to wear the PPE for somebody who had MRSA. And we can support the staff in the decision-making aspect in describing how it spreads by fomite transmission as well, and the harm that MRSA can do. And I feel that we could do a lot more work in supporting the patient interactions. And I've heard it doesn't happen as often as it should, and I hope that that's the way that it'll go in the future, that we interact more directly with the patients, the clients, residents. In this study, in fact, they found that if the patients knew why they were on precautions, they could even help with compliance. Somebody knowing they had MRSA mentioning, oh, everybody who comes in this room wears a glove and gown and washes their hands, for example. And us providing this education to the patients is a value, because really we are the experts on infection prevention. And here are some quotes from the nurses in how education can either help or hinder compliance. For example, the nurses interviewed here do not know all there is to know about MRSA. So for example, providing them with resources that Staphylococcus aureus, for example, is the #1 cause of bacteremias. This bacteria can cause pneumonias, osteomyelitis. I mentioned the bloodstream infections, and pretty much any tissue can be infected by Staphylococcus aureus. It can have high morbidity because they're toxin-producing bacteria, for example. And in giving them this knowledge, they mentioned that this could appreciate them gowning up more. And our presence, so here we have some quotes from the nurses and how our presence will help. Well, help the things that would have hindered compliance. It helps education, the staff with the patients, and the other aspect, the regular audits. I mean, we have to be present to give regular audits, or I prefer regular education in the moment myself. And just a quote from a nurse in this study: I love having the ICP come around, and I do enjoy seeing them on the floor. They appreciate our presence and visibility. And this actually saved me during the COVID-19 pandemic. As an extrovert, the pandemic was hard on the extrovert, but I would go down to the units every day and round. I mean, I think it's a two-way street. I help them, they're also helping me at the same time. Now, patients, as I mentioned, them being part of this circle of interaction can even help with compliance. And certainly patient education is overlooked. Now, I'm not saying we go and talk to every single patient, but when the time is needed, certainly not to shy away from it. And I also think if I can do it, anyone can, because I don't have a clinical background. And even if we're not there, we could support the education with pamphlets, even providing scripts. And what this study emphasized as well is that the staff often felt uncomfortable providing this education because they don't know all the rationale to answer the follow-up questions as we would. So now I'll just ask you guys how you engage the front lines, because I mean, some people, you know, they're covering many areas. Maybe they can't go to a site every single day. And one thing that I would like to mention as well is over the COVID-19 pandemic, there were a lot of meetings I did online, and surprisingly still I could make connections. At first I thought I couldn't, not like in person, but you can. In-person rounds, learning names. Learning names is wonderful. I wish I had that talent. I'm really good at remembering songs, not names. Engaging learning activities.
Erica, in the chat, we have daily visits, being present.
These are great. Engaging learning activities. The learning activities I want to hear about. Honest communication, that's true. I heard that story, was it Maple Leaf Meats, where the CEO is all like, yeah, I made a mistake, I'm sorry. And people appreciated this honest communication. Wonderful. Asking if they need anything. Yeah, it's true. Like some people say that's not my job, and now I'm a little bit less like that. I'm like, you know what? If I help them, they'll help me. Like I'll pick up a tray and I'll bring it to the dirty tray area, because why not? I'm also part of the team. And then what? Oh, and then I want to see what settings you guys practice IPAC in Nova Scotia. We've got acute care, long-term care, public health, dental, other congregate settings. And the other congregate settings, like things like shelters, outpatient, ambulatory, others for anything I missed. Ooh, other congregate settings. The other congregate settings, whoever answered that, would you mind telling me what setting that is? I'm interested.
Hi, Erica, it's Michelle.
Hi.
I help support our correctional facility here in Cape Breton.
Oh, wonderful. Oh, yes, 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 I've heard of that. Like IPAC in correctional facilities. And this is great too, because these are people who haven't gotten the best in the social determinants of health areas. So certainly I feel like our value will be greater there in a way. Let me see. Thank you. Thanks, Michelle. Oh, and then how often do you speak face-to-face to patients, residents, or clients? You could answer never, because some people, they just, I guess it may just be a nature of the role. Almost never. Once. Ooh, daily. Wow. Very nice. Ooh. Wow, this is great. Wonderful.
Erica,
Yeah.
I'm just going to interject just for a second to let you know you've got about 10 minutes left.
Thank you. Such a good moderator. But that's fine, because I think I could do this in 10 minutes. So now I just want to focus on that patient education, where I feel we could do so much more. Now, this is a study from 3 healthcare organizations in Ontario, finding the majority of the frontline staff, 71% in red, did not feel comfortable explaining to a patient or a visitor what a CPO was and why they were on precautions. This is from, they interviewed 514 staff, 65% of them were nurses, and they also found that the patient often felt stigmatized by the staff for having a CPO. So back to our communication amongst the 3, we can support in the patient's communication, talking to the patients to reduce stigmatization. One example I'd like to give is I had this patient, he had neurosurgery with and an infection with a CPE. When he went back to the surgical unit, he was concerned that he couldn't leave his room, especially when he went to rehabilitation, because he wanted to get the exercise. It was summer and he wanted to go outside and he was being shut in his room. So I went to him, spoke to him about CPO transmission and mentioning how to prevent spread, which is really by washing the hands. And he was fine to do that. And like I alleviated his concerns. He was able to leave his room, and I even connected with the rehabilitation IPAC person, letting them know the concerns so there could be a care plan. So he could do his rehabilitation, he could go outside. And this is extremely important because a lot of worry for these patients is, what am I going to do after I'm discharged? And I don't want them to think that they're like going to be a risk to their family. So the final study is how we're integrated and how we're important to healthcare teams. This is a study preventing antibiotic-resistant bacterial infections, where they have measures pre and post implementation of these quality improvement projects, successful projects. They interviewed various members of the team to see how they interact with each other, and constructed knowledge networks. This knowledge network on the slide, this is from a project where they reduced ventilator-associated pneumonias, or VAPs, in an ICU. You could see the large black oval, that's the team in the hospital. The ICP is circled in red. And this larger red oval, this is the core project team. So you could see we're there in the front line with the ICU nurse and the respiratory therapist. We could also extend our knowledge network outside of the hospital or the organization, as you see by these red ovals. To the right, you could see this ICP connected with another facility, and to the left, they connected with outside health or public health organizations. So CDC would be like, for example, Public Health Agency of Canada, IPAC Society, IPAC Canada, like what we're doing now. I still have connections to the research community because I always love science. And you could see to the left an ICP expert. So in this specific study, the ICP in one of their national IPAC gatherings met an ICP who is an expert on VAPs. So they were able to take that knowledge and put it into their knowledge network in this ICU. So this study found that boundary spanning connections are important to the innovation process. So here we have some themes they got in studying these knowledge networks. Number one, ICPs who have worked for a few years as an ICP can draw value from their long-standing relationships, also knowing how things get done at the organization. And the education element, local data is important for the knowledge network, as well as it is for affecting influence. We can bring to our teams knowledge from our professional societies, governing agencies like Public Health Agency of Canada, local public health agencies, and we could also bring into our knowledge network our benchmark data, published data, and of course, connecting with the scientific community and the vast amount of scientific literature that's out there about our field. So now, bringing it all together, we know what ICPs do. Oh, and we know we're effective, but where are we going in the future? And I'll just like to start off saying our work matters. We've got data to show we save our organizations money, but it's not just about the money, it's improving outcomes and saving lives. And I'd like to thank you all. I know the COVID-19 pandemic was rough, but you all did really great work. So time to give yourselves a pat on the back. Happy IPAC week. And I mean, we need to continue to show the world, show our healthcare teams that we are knowledge experts. We have specialized knowledge, and we can bring that unique knowledge to complement our teams. And it's important that we do this to as many people as possible, from the very top to the front lines. But I think that our value will be even more demonstrated if we go more so into the front lines, involve the front lines as possible. And you could tell I'm much more of a bottom up than a top down kind of person, but I really do feel that will affect the greatest change, that we are present to get into the front lines, develop relationships, and empower people on the front lines, bringing them the tools they need to help them make the appropriate decisions to come along on preventing infections. And actually, I want to end on something that just happened today, which like is such a perfect way to summarize like infection prevention.
Erica,
yeah, sorry,
I'm sorry. We have a question in the chat. No, before
Okay.
you do your final thought, I just want
Okay.
to ask the question. What are your thoughts on the importance of building an IPAC culture within a facility, starting with frontline staff to achieve long-lasting IPAC change?
What do I think of it?
What are your thoughts on the importance of that?
Of building it with the frontline staff?
Within a facility, starting with the frontline staff to achieve long-lasting IPAC change.
Yeah, I mean, I really think that it'll be the way to go, developing the relationships. And if you go with the front line and you get them along with you, they'll affect much greater change, because like the front line's everywhere, and the front line is at the intersection with the clients, residents, patients. They will be the ones preventing the infections. I can tell them things, teach them, but I mean, they're the ones that are going to be preventing the infections. And yeah, I just wanted to mention, like today, it was, I'm like, wow, thank you for letting me talk about these things and making me feel really happy. There's this housekeeper, and I think they were just working for a term, and today was their last day before they go somewhere else, and they were going on a vacation. But you know, they said thanks for telling me these things, like reminding them in the moment, because she said, you know, I may not know everything, but I'm just trying to do my best. So thank you, because like, I mean, people, they do want to prevent infections, and we just have to help them. And I really don't like being perceived as the police. So, and she didn't want to feel like she was doing things wrong. And it's like, are they doing something wrong? Like their intentions, we just have to help them along. Like the healthcare workers, they have intentions to help. Nobody goes to work thinking, I want to give this person an infection, I want to kill this person today. So yeah, thank you very much.
Very accurate. Thank you so much, Erica. I just want to say thank you for acknowledging Infection Control Week, because I did not do that. I kind of forgot about that today, wrapped up in getting the conference going. And
I want to see your face, but I'm not succeeding.
Oh, I agree. Our work is important. And some key takeaways for me from your talk were: invest in your IPAC professionals. We all know how valuable that is. We see it all the time. A dedicated role for infection control in your facility makes a difference. So we need to lobby for that hard. And then those key relationships. That is, for me, one of the most important factors. Relationships with my IPAC colleagues and relationships in the areas that I work. So important. And I would argue, Erica, you have plenty of charisma. I've known you for a long time. Don't sell yourself short.
That's the first time the word's ever been used to describe me in my whole life.
Thank you so much, Erica. We really appreciate it. And we will give you the rest of your Friday back. Thank you so much.
Thank you for you guys. It's
Of
like
course.
late on the Friday, so.
For everybody else, we have, you'll need to leave this link and join the virtual conference wrap up and prizes. We have some exciting IPAC Nova Scotia announcements on our work and plans. We have fun prize draws that you have to be present to win your prizes. So I'm going to end this now, and we will see you guys in the next meeting. Thank you, Erica.
I can see you now. Thank you,
good.
everybody.